we keep hearing this, we don't have enough tests, we don't have enough tests. And I think for most people, that's kind of confusing to understand. What's so complicated about this test? What's so unique about it that we don't have enough? Talk about that.
Sure. So the actual test is not complicated. It's a very simple test. You take the virus, you have primers to identify the virus, and you say basically the virus is there or not. But the complicated part of this was up till February 29th, 2020, CDC was the only place where this test was designed and developed, and they were the only one who were doing it, either CDC or the state labs. So that prevented a lot of the labs, academic, CLIA, private labs, to design, develop the test, and do the test. And you're talking about the entire country. So on 29th February, under the guidance of the federal administration, FDA gave new guidance that new labs like us can design and develop this particular test for coronavirus. So that was the major limiting factor till the end of February.
And was the reason for the CDC like a quality control thing? They wanted to be the ones testing it because we know so little about this virus?
Yes and no, because there was little known about the virus till November of last year. But you got to remember there's a lot more information about the virus. The virus has been sequenced. Millions of these tests were done in China and South Korea and Japan and that part of the world. So there was a lot information available on that part of the world. But you're absolutely right. I think CDC did determine that the quality control would be a major issue. And that was one of the reasons that the test was performed as well as manufactured at CDC for a long period of time.
And so why the change? Why did they open it up to labs like yours to be able to test for the virus?
So two things, not two things, multiple things. One thing, we realized that it's going to be a pandemic soon. Mm-hmm. And the only way you can control a pandemic is you test and quarantine. Mm-hmm. So if you want to test a lot more number of people, the test has to be available for broader labs. CDC doesn't have the capacity to test all or most of these patients. And then the new guidance from the President Trump and Vice President did make sure that the test is available for broader residents of the states as well as the country.
Can you walk us through the test? So yesterday we walked people through the pre-screening process for AU Health, which is they go on the app, they get pre-screened, they can go to the drive-through center. We saw the swab go up the nose. What happens after that? Because that encompasses the test, correct?
Correct. So once the swab is done, the initial screening is we do test that swab for your regular respiratory viruses, which is the most common cause of these symptoms. And then if they're negative on those respiratory viruses, these samples are the ones which we select for COVID-19 or coronavirus testing. And when the sample is decided that we need to get that testing, it gets sent to a lab like us. We take the sample and we pretty much do the test to identify whether the virus is there or not.
And so it might be complicated because I'm sure that this is high-level stuff, but when you guys say you take the sample and you test it, what exactly are you doing to that test in your lab?
So technically, it's relatively simple test to do in comparison to other complex tests, especially on oncology or other even virology testing we do. What we do is, the way this test is designed is we are looking at certain regions of the genes on the coronavirus which are conserved across the populations, and we have designed probes which go and bind to that particular region, and then it's a PCR based test, and then if the virus is there at a certain level of copies in the patient, the test is able to identify that rapidly within 2 to 3 hours.
So what is a PCR test? We've heard a lot about that, and I'm sure that's a little complicated, but if you could try to simplify, what is a PCR test?
Sure. PCR stands for polymerase chain reaction. What it does is, this is a very basic technique used in molecular labs to identify any genomic target. So you identify a target, a genomic region, which you want to see if it's present in the sample or not. And you design these probes or targets which will go and bind to a certain region of that particular target. And then it will increase its quantity, which we call as amplification. And that amplification or increased quantity is detected by multiple methods. Most of these methods are fluorophore based. So if there is an increase in quantity, the fluorophore in the system will identify that, hey, it has 1,000 copies of that particular target, or 10,000 copies, 1,000,000 copies of that target. So that's the basic technique for PCR or polymerase chain reaction.
So Dr. Kolhe continues to talk about how fortunate Augusta University Health and the Medical College of Georgia are to have your lab, the GYM lab. Why is your lab so unique? Other hospitals don't have this resource. What about it kind of sets it apart from other medical centers?
So number one, it's a part of the Department of Pathology, so we have access to very smart people in the department who are pathologists, microbiologists, as well as postdoctoral research fellows who are very dedicated to do bench work and research and combine those two expertise to do work what we call as translational pathology or translational medicine. So just to give an example, and the other thing is it's also a CLIA lab. So it's a state-approved lab for high complexity testing. So those two things differentiate what the GEM lab is. You will have multiple labs in the city which are CLIA certified, but they won't have these kinds of academic as well as pathology support. So the GEM lab is a platform where these two kinds of groups come together, and we could design something like coronavirus testing in a short period of time, inbound with the state as well as the federal regulations.
Perfect. We're hearing a 48 to 72 turnaround time for these test results to come back for patients. Why that window for when somebody can show up, get swabbed, and then find out their results?
So the biggest challenge is at this moment there are very few labs in the country who could do this testing. And these are mostly national reference labs. So at the moment, if you go to any part of the country where there is no academic support, so even if you take the state of Georgia, I was on a call yesterday with the task force, and based on what I was told, there are, apart from CDC and Department of Public Health lab in the state, we have only 2 labs, one at Emory and one in the GEM lab, who have the capacity to do coronavirus testing. So you can imagine for the entire state, technically you have only 2 labs apart from the state and CDC. And that is pretty much the picture all across the country. So a lot of the community, the docs, the clinics are doing is they're sending these samples to these central reference lab. Actually, we also do that because we are very small in capacity. So the moment the sample is taken from the clinic, there's a courier which gets sent at a certain time, let's say 3 o'clock, 3:30 in the afternoon. It reaches to the lab, and most, if not all, these labs are backed up for 4 to 5 days because they're getting hundreds, if not thousands, of these tests all across the country. So not only there is an issue with the transport to the central lab, but also these labs are backed up with already pre-existing specimens from all across the country. So that adds a huge amount of delay on their side. I think the reference lab are doing a phenomenal job, but the scaling up of these tests is a monumentous task for everyone. And that also relates to the supplies these labs have and the capacity these labs have to test these kinds of volumes.
So with that, with the amount of volume that we currently have, we were talking the other day, we understand that there were people who showed no symptoms at all who still have a fear that they have the virus and they want to get tested. Why is it so important, though, to reserve these tests for people who clearly show symptoms? Can you talk to the population kind of about that, why it's important to reserve this for those who really, really need this test?
Sure. So the two things with it. One, at this given moment, we suspect that a lot of people have been affected by the virus. They may not show symptoms, but that is absolutely okay. But the patients who are at high risk are the ones we want to test and isolate them. The patients or the individuals who have high risk to be exposed to other patients like healthcare providers or first responders, which their job is to be on the front. So we want to make sure that we are identifying those individuals and isolating and preventing exposures of other people to those first responders and healthcare providers. So these are the things, these are the categories we are looking at, which makes a lot more logical sense to prevent the pandemic instead of just testing the healthy carriers at this moment. But there will be a time once the capacity improves, we will end up testing individuals who might be what we call as healthy carriers, and then identify them and quarantine them. But I think at this given moment, the majority of the focus is patients who are symptomatic, to make sure that we identify them, and they might be the ones which are having a high viral load and more prone to secrete the virus and more prone to infect more people as compared to non patients without any symptoms.
Right. What is it that's currently scarce about the test? Is it the actual swabs? Is it the personnel? Is it the time, 24 hours in a day? Because when we hear there's a shortage, I want to latch onto something that's like a physical scarcity. What is it that's scarce that makes these tests in low supply?
So for the testing, if you want to put numbers, I would say there are 4 things which are actually scarce. You can start right from the swabs, which we want to collect. They're actually in a significant scarcity nationwide. So that's your beginning limitations to get people swabbed in. So that's number 1. Number 2, the raw material and the plasticware for these tests. So that has a significant delay from the manufacturers. And one of the biggest challenge is these plasticwares for some companies was manufactured in China. So that has not been happening because of the disease there. So that is another reason that there's a significant delay in getting those, because we need these plasticware. Number 3, the actual ingredients for these tests. At this given moment, there are very few companies who can make those ingredients. And then these companies also are getting these huge orders, and that make them a pretty significant backlog for that. And last, the 4th reason I think is also the time and the capacity of these labs. So majority of the labs, when they're running 24/7, 3 shifts, there is a limit to a human capacity, as well as the machines who could scale up in a very short period of time.
Right.
And I think these are the 4 reasons why, in a very short, me talking about the guidance from FDA came on February 29th, and today is 19th March. So we only had 20 days to actually get ready, validate ourselves, and start testing these patients. So in the last 20 days, we have realized these are the 4 most important reasons why there's a shortage or delay of these tests.
Who are you guys currently testing at this gym lab at MCG? Is it across the country, the state of Georgia? Who is your focus currently?
So at this moment, we get most of our tests under the guidance of Dr. Kool and his team, which they think they are high risk, and we want to isolate them as quickly as possible. One of the advantages of the test which we have designed in the lab is it is rapid. So we give out results in 2.5, 3 hours. So one of the main goal of designing this test was, if you've heard about patient 31 in South Korea. So the patient 31 in South Korea was the reason why the whole epidemic happened in South Korea. So anytime you want to isolate that one patient which is with high viral load, which has a capacity to being exposed to multiple people. So that was our main goal, to have a rapid test and then identify these patients with high viral load. So at this given moment, we are testing mostly this high risk, or we have a criteria on the clinical side, and based on those criteria, we are identifying those patients and testing them.
So I heard you say earlier that you were on with the task force. I imagine that's the governor's task force, Georgia's task force for the coronavirus, correct?
Correct.
What are you on that call for? What kinds of questions are they asking you? What expertise are you providing to that task force moving forward?
So yesterday was my first call. I think it's a process. It's very early in the process. As I get more and more information, I'll be more than happy to talk about it. But at this moment, I think we are looking at what statewide resources we have to scale up the testing and multiply our capacity. So that's what we are looking at this moment.
Are there other hospitals across the state of Georgia that could potentially up the scale, or is it only limited to those 4 that you listed before?
No, it is not at this moment. I think the FDA came up with new guidance on March 16th, the Monday, and basically what FDA had said that we don't need any more FDA approval to get these tests. So it's up to the state to decide which CLIA labs can do these tests. So that opens up a lot of state approved labs to get these testing and provide it to a bigger population. But the challenge which we are facing with the shortage of plasticware and the supplies is going to be the constant denominator for all these labs. So it will be expanded, I'm very sure, but I think it will be dependent on how much the supplies are available for these labs.
What are you guys currently doing in a 24-hour period, and then what is the goal? What will it take for you to get from where you currently are to that goal?
So at this given moment, we are doing 72 tests in 24 hours. Middle of next week, we're getting one more instrument, which will scale up to 300 tests in 24 hours. We're also validating additional platforms, additional instruments, which will help us on top of these 300, 500 tests per 24 hours. So not only we are dependent on one platform or one test, we're also looking into validating additional platforms to scale up what we already have in the lab. But again, you have to remember the biggest limiting factor at this moment is the plasticware and supply. So even though we are planning to do it, we are at the mercy of these suppliers to get this stuff in the lab. But as far as our lab is considered, we have already started the process of validating another platform, another instrument to scale up the testing process.
Where is that instrument coming from?
So we have the instrument in the lab, but the plasticware we have to buy from the suppliers.
Got it. Who is in this lab? Is it residents, PhD candidates, pathologists from across the healthcare system?
The lab has pathologists. The lab has 4 PhDs who pretty much are dedicated to this process. We have research associates, we have lab techs, and in the last, I would say, it took us 100 hours to get this test and validated, non-stop effort from this lab for 90 hours over the weekend. We made it sure that we could get this validated and submit to the FDA for approval. But at this moment, it's not required for approval, but we are still continuing on that process. But it was a non-stop, phenomenal effort from my lab, which was we were able to do that, and the commitment was to bring something to the community rather than waiting for 48, 72 hours for send out labs. Yeah. And when I was asking my lab techs, the initial plan was to do 8 or 12-hour shift, but the idea was, the response from the lab techs was, it's better to come in the lab and do something rather than sit home and watch depressing news about things happening because of coronavirus. And it was actually more fulfilling to do and work in the lab rather than standing in line at Costco for supplies.
So why do you think there is that commitment from your lab techs to your PhDs to the pathologist willing to work 12 plus hours a day on this? Why do you think they're so committed?
I think these are unprecedented times. We have this particular generation has never seen something like this before. This was our time to make sure that, and this is what we are trained for, to design a test, validate a test, and do the testing. And everyone felt that they need to put as maximum they could do on these efforts to make sure that we could do something locally in the institution so that the rapid turnaround time could be met. And then I think this is more of a commitment from the lab as well as the department, not only for the institution, but also for the city and the CSRA region.